Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
This is Josh Sharfstein. A brief announcement. The COVID-19 pandemic introduced the terms epidemiology and outbreak response to new audiences. If you have become interested in a career detecting, investigating, or analyzing data from outbreaks, you can now take a free course to learn more on the Coursera platform from Johns Hopkins. Go to Coursera.org and type in Investigating Epidemics Like COVID-19 and Analyst's Guide. That's Investigating Epidemics Like COVID-19, an Analyst's Guide. Today, we return to the topic of masks and COVID. I catch up on the latest reports with Johns Hopkins professor and infectious disease epidemiologist, Dr. David Dowdy. Let's listen. David Dowdy, thank you so much for joining me on Public Health on Call to talk about masks and COVID again.
Thanks so much for having me, Josh.
So we thought it would be a good idea to cover this topic when there was a whole other round of headlines about masks and COVID. And people like my mom were calling me saying, maybe I should never have worn a mask the entire pandemic. Is that right? I don't know whether you've seen these headlines or you've heard about what people are talking about.
Yeah, so I've certainly seen the headlines. I think it's easy to misinterpret those headlines as thinking that the science has somehow changed. I think the important thing for people to realize is that masks still work. They always have worked. It's just that you have to use the right masks and wear them the right way for them to work. That's the way it's been, and that's the way it still is.
Let me ask you to walk through the evidence for that. On what basis would you say using the right mask in the right way is going to protect someone from COVID?
Right. So I think it's important also for people to realize it's hard to get randomized trial level evidence here because you can't really ask people to walk into a room where you know other people have COVID and say some people wear a mask and other people don't, and we're going to randomly allocate that. So we have to do the best we can by piecing together evidence. And this evidence comes from observational studies where we look at people who have been wearing masks and see that they have lower rates of COVID, but also years and years and years of dealing with other airborne infections as well. Whether this be, again, we're talking about COVID-19 or something like tuberculosis. And so we know what the diameter of the droplets are that carry these viruses, and we know what the diameter of these masks. It's almost like, do I need to do a trial to know that pieces of pasta aren't going to fit through a strainer, for example? So we know those measurements and we know the right sorts of masks, so like N95 sorts of masks, respirators, how they're designed to keep those particles out.
Sounds like what you're saying is first you've got the design, you've got a theory for why they work, you've got the design argument for why they work, and you do have some evidence that it works in different settings, from medical settings to other settings. As people report wearing masks more, they may suffer from fewer infections.
That's right. So there are a substantial number of randomized trials, but observational studies where you either ask people about their mask wearing behavior, or in some cases observe it or ask them to document it and see what the rates of getting COVID are among those who are wearing a mask more frequently versus those who are not. It's not perfect, but nothing in science is ever perfect. And I think we're frequently in a situation of trying to make the best decisions we can with the best evidence that we have. And I think that the majority of the evidence we have is in the direction that the masks lower one's risk of getting COVID infection.
Now, there have been some papers published recently that are looking at randomized data and saying, aha, we don't see strong evidence that masks work across different respiratory pathogens. And in these studies, people were randomized to whether or not they were going to be wearing different kinds of masks. How do you interpret that data?
The way that I have interpreted those particular studies is that on one hand, it wasn't enough power to see an effect, right? So even though they are randomizing people, they didn't have enough infections in either arm, or they were doing a meta-analysis where they combined lots of different types of studies. But since they were different types of studies, they got different sorts of results. There wasn't the power to see a definitive difference. But I think, again, what we have to ask ourselves, given the entire spectrum of studies that have been out there, those that are and are not included in any one analysis, what's the overall direction of the evidence? And I think that direction is clear.
Now, you did mention that your conclusion really only applies to certain types of masks. Could you talk about that a little bit more?
Yeah, so we have seen different sorts of studies looking at cloth masks, for example, versus the sorts of masks that are designed to keep these airborne particles out. And those masks are called respirators for those who care about the formal language, but you've seen these probably. They're the N95, KN95 sorts of masks. I think that there's a reasonable amount of evidence that the first type of mask, so the just kind of simple surgical or cloth masks, if they have an effect, that effect is relatively small. Whereas the respirators, if worn appropriately, meaning needs to cover your mouth and nose and needs to fit well around your face, do substantially reduce the risk of transmission. And there have even been a few head-to-head sorts of studies that have suggested this as well. Some of this is also just based on the knowledge of these masks and how they are put together. Even before COVID, this is what we recommended for airborne infections, right? So if we were dealing with someone who had an airborne disease in the hospital, we would never say you could just wear a surgical mask, and nurses would always put on those sorts of respirators. This is nothing new having to do with COVID. We know how large these particles are. We therefore know how well designed a mask needs to be to keep those particles out.
What about the question of fit testing? You know, sometimes in workplace settings like hospitals, you double check to make sure that masks are protecting you. With so many people using masks now and people buying masks from the internet, there's not really the opportunity to do that. Do you think people are still getting some protection from those masks?
I think in general, yes. Obviously, there's a range. And if you have access to a professional fit tester and can wear a mask in that fashion, then that's the gold standard and certainly will offer the most protection possible. In many cases, even if you can't get that professional fit test, if you're able to make sure that air is not seeping around the edges of the mask, that is certainly offering more protection than nothing. But of course, anyone can wear even the best of masks in the wrong way. You could take an N95 and pull it down over your nose or just hold it off your face, and that's not going to do any good.
There's also this discussion about mandates for masks. Let's say we could agree that there is value in protecting against COVID through wearing the right kind of mask. There's some people saying there might be, but you'll never get enough people to wear masks correctly. There's no proven value of a mandate for a mask. How do you think about that question?
I think of this as a risk-benefit of equation. I think that we know that there are some behaviors that people will only adopt if there is a mandate in place. So people won't wear a mask, but if they're told that you have to, then they will. That will offer some level of protection at a population that wouldn't have that protection otherwise. But that comes at the risk of people feeling like they're being intruded on by the government. And so I think you have to try and weigh how much benefit you're getting from that mandate in terms of people who would be wearing that mask who otherwise wouldn't, and how much not physical risk, but psychological risk that you incur by people feeling like the government is overstepping and telling me, intruding in my own personal life. I mean, I think that we need to be trying to enact policies that help people feel like we're all in this together as a society. And I think in some cases, mandates help that. In other cases, they might not.
And in some places, they may help that. And in some places, they may not.
Exactly. Yes.
Well, that is a very thoughtful response. I really appreciate the chance to check in with you, Dr. Dowdy. And I think that I'm going to encourage my parents when they are around people indoors and they don't know who they are or that they're COVID-free to have some high-quality masks at the ready.
Yeah, I think that's absolutely the right guidance, is that if people want to protect themselves, masks do help. And thanks so much for having me back on the show.
And I'm back. This is Josh Sharfstein with one final note. After we recorded this podcast, the editor of the journal that published the paper we discussed, casting doubt on whether masks work, made a statement. She said, quote, "Many commentators have claimed that a recently updated Cochrane review shows that masks don't work, which is an inaccurate and misleading impression." She added, quote, "Given the limitations in the primary evidence, the review is not able to address the question of whether mask wearing itself reduces people's risk of contracting or spreading respiratory viruses." End quote.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith-Rogers, and Stephanie Desmond. Audio production by J.B. Arbogast, Holly Cardinale, Philip Porter, Spencer Greer, and Matthew Martin, with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo. Social media run by Grace Fernandez and Shian Briscoe. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.